Most Americans haven't heard of PBMs.
PBMs are strong. They're powerful. A lot of money, and they spend a lot.
PBMs are probably the biggest companies that you've never heard. America has two drug problems. One is illicit drugs, and the other is PBMs.
The United States has the highest drug prices in the world. By far, the United States is the only country that has PBMs.
They turn the clocks and cross the lines, build their empires on borrowed time. But its time is ruthless, it does not bend. It turns and loops, it finds the end. Every silence builds an arc. They can't escape this. Their cracks will start to show. Their truth will break free. It's stronger than they know.
My name is Dan Strauss. I'm a little bit of an odd duck, and maybe the person that's main job is to translate complexity into Main Street. I started my career as an accountant for a Big Six accounting firm, and I only bring that up because every 3 weeks we went to a different type of job, and with that you knew absolutely nothing about that industry, and you learned to ask smart people questions. And at the end of 3 weeks you became intelligent subject because you asked questions. And when it comes to healthcare and PBMs, etc., it takes a lot of questions, and we're also trained in healthy skepticism. Trust but verify. And what you'll find out later when it comes to healthcare, there's a lot of trusting on false assumptions that nobody verifies. It turns out not to be true and harms an awful lot of people. And then I had a good friend about 22 years ago that stated that he wanted to be able to buy 5 pharmacies. And I looked into it, and pharmacy is a very odd business, as we'll find out later. But we went in with the very core mission of pharmacists: you take care of patients and get patient outcomes. I'll take care of you to make sure we're solid. And we were very much pragmatic, right? We are your typical Main Street rural type of farm community strong. We do a lot of things ourselves. Turns out folks liked our style. So we went from 5 stores to 7 to 12 to 17. Then we ended up to 70 pharmacies. And we had our own health plan. And our own health plan, we had the same issues that everybody else did. That our premiums were going up 15, 20% every year. We'd look into it and says, well, that's just the way it is. And you couldn't afford that, so what would you do is you would raise co-pays, lower benefits, and that same song and dance for too many years. And then we have the 1 year where we supposedly had a good year where we didn't spend as much, and they said, well, you're still going to get a premium increase. I thought something is absolutely wrong. And our own health insurance plan, we started digging deep. And then that's where we started finding a lot of issues that we'll get into later. When you're a pharmacy on Main Street, you get to meet an awful lot of people. I'm very, very proud of our pharmacists because we have a reputation of really taking care of people. And with that, people tell us what's happening to them. And it's absolutely soul-crushing and mind-numbing, the things you see and says, this just cannot be right. So the first time you hear something, you says, well, that must be a one-off. Then you hear it again and again, says, no, we got a problem here. We need to start asking questions. And then you look around the country, ask questions, no, this is actually worse than I thought. And this whole mission of this docuseries has been an explosion of that, where we think there's 10 things wrong. It's really 20, right? So it is complex, but the nice thing is when you ask enough questions and you trust and verify, Now you can find a way to take complex situations and break it down so we can explain it to our family and friends on Main Street. You know, there's a couple of very personal experiences that I think a lot of folks can relate to. First, I'm going to talk about on the patient side, then two is an employer with the health plan side. So the first one, we have a wonderful aunt that all of us dearly loved. And she used to come in the pharmacy and she was on a generic medication where her copay was $10. And she would come in the first of the month with $20. She'd buy her medicine, but then also buy $10 worth of candies and goodies. And on her way home, she would stop and visit 10 different folks to just spread a little love and a piece of candy. One January she comes in, and her insurance company said, you no longer can get that generic medication for $10 that you've been on for the longest time. Now you have to take a brand, and it's going to cost you $75. She still only had $20. So now she's in tears. We see that. There's no way we're going to let her leave without her medicine. But there's where it's like, this is wrong. How can a good generic that did the job well for so many years all of a sudden not be good enough? And you realize it's a form of extortion. When people are forced to pay more for the price of drugs, this is healthcare. You know, this is just wrong. So that left a deep scar and created an awful lot of questions. Then secondly, our own health plan. I had to fight for almost a year with our health insurance company to say, I'd like to know my spend on pharmacy. This is our own medicines coming off our own shelves, given to our own people. Well, we can't share that with you because of HIPAA. No, I don't want individuals' names. There's nothing about HIPAA. I know how much came off our shelves in dollars, how much that cost our own health plan. And I almost had to threaten a lawsuit, and finally I got it, and I realized why they kept it a secret. $60,000 of medicines came off our own shelves and went into our own people's hands, and our health plan charged us $360,000. Now, that is just wrong on so many levels, and that was an eye-opening moment. If they're doing it to us, what are they doing to everybody else? And we realized we just came upon a nugget of information that most folks never have privy to. They aren't marking up 10%, they aren't marking up 6%, they're marking up 500%. Who's benefiting? Them. That's like a skim off the top. Them are health plans and PBMs.
The PBMs, their history, it's kind of interesting, that they were created in the late 60s, early 70s. And back then, prescription insurance was still a new thing. A lot of people didn't have prescription insurance yet because prescriptions were still not very costly. They were still pretty inexpensive. But as time went on, there were more breakthroughs with prescription drugs, and some of those prescription drugs started to cost more money. Patients would pay for the prescription drug and then have to submit the bill to their insurance company and wait to get paid back. So the concept, at least on paper, of PBMs was actually something that was good. It allowed patients to be able to submit their insurance claim on the spot. Pharmacies were some on the cutting edge of technology. So the patient knew right away what they were obligated to pay and how much their insurance company would pay. The patient didn't have to submit and wait for their money to come back. And for the pharmacy, it was, at that point, it was helpful for the patient, so it was good for them, and it allowed that pharmacy to get paid in a timely manner. The cost back then was a transaction fee, which I think was in the pennies for this transaction fee, and that was the end of it. And it was also transparent. Here's your transaction fee. I don't know the number, but let's just say it's a nickel. You paid a nickel, and for that you gained some efficiencies, and everyone's happy. I wouldn't think there'd be a lot of regulation needed back then because it was a simple, straightforward task.
You know, the reality was, and when I started back in pharmacy, patient would come in, give you a paper prescription. You would just kind of guess about what their coverage was. But again, this was back at a time where we just had brand and generic drugs. We didn't have $1,000 drugs. We frankly didn't have hundreds of dollar drugs. So you didn't have to worry about the insurance coverage as much. Things were much more affordable. It was much simpler because we were just dealing with pills. And so you could basically manage off that piece of paper. It wasn't easy, it wasn't great. There was a lag in payments lag in coverage. Formularies were just starting to come out 30, 40 years ago. So the concept that first started was, we've now got these computers, we've got technology, and a PBM could sit in the middle and say, hey, pharmacy, here's the drugs that we want to cover, and here's how we're going to pay you, and you could do that in real time. And then it really started to expand because self-funded employers, Medicare, Medicaid, as they started looking into this insurance coverage for prescription drugs, they needed to be able to create a network. Do I want Walgreens in network? Do I want CVS in network? Do I want independent pharmacies in network? Then they could start creating all the rules. So then the PBMs took this very complex world and made it easy for employers just to contract with them and manage the whole benefit on their behalf.
The simplest form to say it is when health plans start covering prescription medicines, let's say company X and company Y each said, well, there's 100 pharmacies in my network, I don't want to write 100 checks. And the pharmacies themselves says, well, I don't want to get 100 checks from 100 different companies. So PBMs were simply in the middle and say, okay, company X, write me your entire check, and so will 20 other companies, then I'll take that and then I'll write the checks to the pharmacies. Well, that works. It was great for the third-party administrator, for the employer, and pharmacies, we liked that to begin with because it made life simpler. That's why they existed for so long. And why nobody ever heard of them, because whoever hears about the paper pusher that's doing this.
And again, 30 or 40 years ago, it was off an admin fee. They were really this pure thing trying to help, I think, community pharmacy get paid better and run a more efficient operations, and then employers figure out how to bring a better benefit to their members.
The original idea was a good idea, and it was a processor that created some efficiencies in the marketplace. So the early start of PBMs was not a bad thing. It's changed.
I would say really over the last 10 years is they've then grown, and we've seen consolidation from 20 PBMs to 10 PBMs to, let's face it now, really just 3 main PBMs that are all owned by huge healthcare conglomerates that are really 3 of the biggest 10 companies in America by revenue, and their whole goal is to work on behalf of their shareholder. Now we've lost that purity of what a PBM used to be, and they're just trying to make as much money as they can for their shareholder, and that's always at the detriment of the American economy, the American corporation, and definitely the American family.
Well, as we'll find out when we talk about history, they went from a paper pusher that had no regulation into the most powerful folks that impact the cost of medicines, and now are literally extorting people because they have the benefit of not being understood. In our journey, we find that if you talk to 100 people on Main Street, often less than one has ever even heard of a PBM, much less know what they actually do. Everybody knows there's a problem. Who's the bad guy? How did we get here? Where did they come from? How did they get away with it? And that was the inspiration of making this docuseries, is we had to explain who's doing it, how do we fix it, and how do we get here?
Most Americans haven't heard of PBMs, and I was no different a few years ago until I started to dig into this industry.
PBMs are probably the biggest companies that you've never heard of, right? Pharmacy benefits managers, they operate in all 50 states.
Never knew never even heard the 3 letters, the term, the nothing.
I think 4 or 5 years ago, legislators had no idea what a PBM was. Like, they wouldn't even know if you're talking about healthcare if you brought up a PBM.
In my office on the bookcase, there's a VHS cassette that says PBMs 101. VHS cassette, right? That's how long independent pharmacy has been ringing the alarm bells about PBMs. I think pharmacy saw where this was going a long time ago. And I think ultimately PBMs, what they've proven is it's not, if they can feed off of independent pharmacy, they'll eat the meat off those bones, right? But if they can feed off patients, they'll do that too. And if they can suck hundreds of millions to billions of dollars in taxpayer money, everywhere they can do that, that's what they're going to do.
PBMs are like the weeds of the lawn of pharmacy and pharmaceutical world. They are everywhere. They're invasive. A preliminary report from the FTC reported that just 6 make up 95% of all the prescriptions that are paid for in America move through those 6 PBMs. And breaking it down even more, 3 of those 6 PBMs account for almost 80% of every prescription. So patients, pharmacies, pharmaceutical manufacturers, payers, they can't make a move without talking to these 3 PBMs that account for 80% of all the prescription traffic in the country. And all 6 of these, by the way, not surprisingly, are PCMA members. PCMA, they're the Pharmaceutical Care Management Association, a DC-based lobby group. Hi, I'm Doug Hoy. I'm the CEO for the National Community Pharmacists Association. I'm a pharmacist. I grew up in a community pharmacy. My dad's a pharmacist and practiced for several years before coming to NCPA. NCPA, we're the National Community Pharmacists Association. We've been around for over 100 years, and we represent independently owned pharmacies, the small businesses. Some people say the mom and pop shops, but the community pharmacies, the almost 19,000 of these community pharmacies throughout the country. Our mission is to protect and preserve independent community pharmacies. So the reason we need to protect and preserve independent pharmacies is to help patients and their communities, because we see so many patients that don't fit into the big, what I consider assembly line of healthcare. You know, not all patients are the same. They have different needs. And I think in our healthcare system, we try to put patients on an assembly line where all the patients are the same, they need all the same things and all the same care. And I think that really jeopardizes the health of millions of patients. Our independent pharmacies, they are the ones who will take the time, and they're a safety net for the millions of patients who just don't fit the mold of assembly line healthcare. So PBMs have, I can't count how many revenue streams that they have. Even if I could, they mask those revenue streams and won't disclose them.
America has 2 drug problems, right? One is illicit drugs, and the other is PBMs, because they've got their fingers in every possible angle for prescription drugs within the supply chain, right? And so they negotiate with drug manufacturers, and they find ways to suck those rebate dollars to themselves. They negotiate with pharmacies, right? And so they are literally, you hear the word middlemen, but that is right smack where they are, and they use that position essentially to arbitrage on every single side. They use that position to benefit themselves. The unique thing is they've sold themselves for years and years and years as, hey, not only can we administer your drug benefits, and whether that's for an employer, whether that's for the federal government, whether it's for a county, a city, a state government, fully insured client, right? Their sell is, hey, we will manage your prescription drug benefits, we will manage your prescription drug spend, and we will save money. And that's been the pitch. And it's worked to the point where, again, biggest companies that you've probably never heard of, or most people have never heard of. We're talking on the Fortune 500, the biggest of the biggest. You've got companies that are within the Fortune 10, the Fortune 20, and growing and growing and growing. What I think is, and again, no historian here, but it's gotten to the point as more and more data has come out. And for years, it's been pharmacy ringing the bell, and it's been really anecdotal. Right? It's like pharmacists know that they're ripping everybody off. They see that their patients are getting forced to a more expensive brand. They see that a cancer patient is being forced to a mail order pharmacy, right? They've glimpsed, they see these things regularly, and they've glimpsed what's happening on the other side. And so they know they're hurting patients. They know they're acting anti-competitively at independent pharmacy, but they also know that they're not doing right by taxpayers, and they're not doing right by their clients. But it's been anecdotal. And if you look at the PBM issue, and I think it's important because you're talking about the biggest companies on earth, amongst the biggest companies on earth in the history of capitalism, right? The money that they've got more cash on hand than some nations, and that's not an under exaggeration. And so you're going against the biggest companies on earth with literal armies of lobbyists, right? PBMs used to funnel hundreds of millions of dollars, ultimately billions of dollars into their coffers through things like steering, games with rebates, drug pricing, manipulation, drug pricing arbitrage.
I've learned the kickbacks, the rebates, the step process, all those little tactics, as I like to call them. They claim them to be ways to save the patient money or make insurance more affordable, give people the best options. That's just not the case, and there's a lot of wool pulled over people's eyes or something, and it's because it's a money game, and when you got billions of dollars being made, that's what we've learned, honestly, is that there's greed, there's tactics, there's 3 major PBMs, and
Things start to make a lot more sense.
I mean, just that's just the black and white of it. That's the only thing that really comes down and makes sense to I think it all comes back to that. All the tactics are there because they need to make more money.
Oh, it's like a license to print money to be a PBM. They make money from the pharmaceutical manufacturer. They make money from the payer. They make money from the pharmacy. They make money from the consumer. There are fees galore for the pharmacy, and also probably for the payer as well as the manufacturer, and hidden fees to the consumer as well.
PBMs have done like what's prohibited for physicians to do, literally on the grandest scale that it has ever been done, right? They are steering America's sickest patients, carte blanche, steering these patients into their pharmacy channels. And not only are they steering these patients into their pharmacy channels, but they're massively marking up the price of those drugs. And so, is the impact to patient care? Absolutely. Does it disrupt care? Absolutely. Does it delay care? Oftentimes. And then when you look at the data, and again, for years they've said, oh, this is a cost-saving measure. We're saving money. We're leveraging our specialty pharmacies, and we're leveraging our vertical integration in a manner so that, yeah, we own the pharmacy, but we're using it to reduce costs. And then you look under that rock, and we're looking at a large plan in the federal employee health benefit program. We found an MS drug that was marked up 47,000%. Taxpayer money marked up 47,000%. Not normal, right? But yet it happens every day, every single day.
They make more money than the providers on either side of the equation. So yeah, they are the quintessential middlemen. They're the paper shufflers, but they've got everyone by the short hairs because they control the data, they control the formularies, they control the rebates, they control the costs. They have positioned themselves so that they control everything. They don't make the medicine. They never actually touch the medicine. They don't provide any pharmacy dispensing services.
It's not normal, right? And to me, that's the thing. It's amazing what can be normalized. And what's happened is, now drug pricing manipulation has become normalized. We're all living in a world, in the drug world, at a table set by the pharmacy benefit managers. And things seem normal that shouldn't. And, as we try to reform certain things, the problems are so massive that what happens? Folks are starting to look piecemeal. Well, let's just try to do this, or let's try to do this, or let's try to do this. And they can just reset the table. And so they're always 2 or 3 steps ahead. And so that is the world that we're living in, and that's why ultimately what we need is comprehensive PBM reform, right? We need something that is going to take the pen out of their hand so that they're not setting that price.
The drug pricing supply chain is so complicated that it takes a really in-depth conversation to unpick it and to explain what this industry is doing. And the middlemen moniker, I think, is useful in doing that because people intuit once they hear the word middlemen. But at the core of it, it's a very simple proposition, which is that PBMs are middlemen. And regardless of the sector that we are discussing, wherever there are middlemen, value is being extracted without value being added. And that is the problem that we have here. PBMs are extracting $300 billion every year from the US healthcare system, and they're not adding a whole lot in return. People have complaints about pharma. Pharma, at least, is doing R&D on new drugs and delivering cures to the world. The PBMs are paper pushers, and they have shielded themselves from public scrutiny. They have allowed the opacity of the supply chain to become an asset to them in deflecting tough questions. And they've gotten complacent and they've gotten greedy.
We have a thing called the middleman, the middleman, right? The horrible middleman that makes more money, frankly, than the drug companies, and they don't do anything except they're a middleman. We're going to knock out the middleman. We're going to get drug costs down at levels that nobody has ever seen before.
PBMs were created as a middleman to help reduce the price of prescription drugs. The PBMs are not doing what they were created to do. They're not saving the patients money. They're actually costing the patients more money. They're price gouging, and in addition, another part of our investigation They're stealing patients from independent pharmacies.
We're on pace this year to lose one independent pharmacy every day. Whether you're Republican, a Democrat, or independent, we all want the same thing. We want accessible, affordable, quality health care. Pharmacists are the most accessible healthcare professionals in America. If one pharmacy every day is closing, accessibility to healthcare is going to be impacted. A report by the Berkeley Research Group that shows that 37%, only 37% of the price of a drug goes to the pharmaceutical manufacturer, which begs the question, where does the other 63% go?
And put patients before profit.
Take a look at these photographs. These are real people, real patients. They exhibit only a fraction of the Americans who are taken advantage of by PBMs every single day. We have an opportunity right now, an opportunity to advance bipartisan legislation that increases reporting requirements, which would heighten transparency and shine a light on the opaque practices of these PBMs. When I was in high school, I wanted to be a football star. Unfortunately, not only was I short, I was also slow, so it just didn't work out. And I made a deal with my dad. I told him, I said, Dad, after my junior year in high school, and playing football, if University of Nebraska or Oklahoma hadn't sent a scout out to see me, I'll get serious about a career. And I don't know what happened, but they didn't show up. But anyway, I got serious about a career, and after my junior year in high school, I got a job in a drugstore and as a delivery driver. And it was really an omen from God, because I just, it was perfect for me. Healthcare, obviously very extroverted, so I enjoyed working with the public. And I knew exactly what I wanted to do. And I went on my senior year and then went and got my pharmacy degree and came back home and got a job in a drugstore and worked for 8 years as for someone else, and then decided I wanted to give back to the community, to give back so much to me. And I volunteered. I served on the Planning and Zoning Committee, and next thing I know, I ran for City Council, then I ran for Mayor, then I ran for State House, then I ran for State Senate, and then I ran for Congress. So it really is the all-American story. I mean, I've lived the American dream, and I just want to give back to a community that's blessed me so much. And it was my primary focus as to why I wanted to go to Congress. Remember, I practiced retail pharmacy. I was the one who had to go to the counter and tell the senior citizen how much their medication was. I was the one who watched them make a decision between buying their medicine and buying groceries. I was the one who had to go to the counter and tell the mother how much the antibiotic was for their child, and watch the mother in tears as she was trying to figure out how she was going to pay for that antibiotic. I set as my goal and my focus to do something about that. And I knew where the problem was. Yeah, the pharmaceutical manufacturers need to do a better job with their pricing. There's no question about that. But the problem lies within the drug pricing chain. And the problem lies within the vertical integration that exists, where the insurance company owns the PBM, the pharmacy benefit manager, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. That vertical integration is what was leading to the increase in drug prices, and I wanted to do something about that, and I set as my focus to do that. The first thing I did 10 years ago when I got to Congress was go straight to the FTC and say, why aren't you looking at this? Why aren't you looking at the fact that the insurance company, aka Aetna, owns the pharmacy benefit manager, aka Caremark, that owns the pharmacy, aka CVS, that owns the doctor, many clinics. And another example, Cigna, Express Scripts in this case bought Cigna. The PBM actually bought the insurance company. But Express Scripts, they are the PBM, Cigna's the insurance company. Then you got a group purchasing organization, that's part of it as well. Then you've got the pharmacies. Express Script mail order is by volume, I think, the second largest in America. And then you've got the doctors. In the case of PBMs, there are 3 PBMs that control 80% of the market. United Healthcare, according to the Fortune 25 companies, United Healthcare is number 4. United Healthcare PBM is number 4 in way of revenue. CVS Caremark is number 6. And then Express Scripts is number 16. 3 of the top 25 companies in America are PBMs. The FTC, their role is to make sure that there are no monopolies out there. And again, as I point to the vertical integration United Healthcare, I think, is another good example because United Healthcare is the insurance company. They're also the PBM. They have the group purchasing organization. They have the mail-order pharmacy. They also have doctors. They are the largest employer of physicians in America is United Healthcare. 9% of all physicians work for United Healthcare. Now, there's nothing wrong with working for United Healthcare, but 9% of all the physicians in America work for an insurance company?
Doctors, nurses, pharmacists, they're amazing people. They get into healthcare for the right reasons. They're in to take care of the patients. The unfortunate thing is many of them are forced to work for organizations that people will never meet, make the rules, make the decisions, and up at the C-suite level, we call it, that's the CEOs and CFOs, board of directors, whose responsibility is to their shareholders, that their job is to make money for their shareholders. And so the way the game has been, I won't say rigged, because as we'll go into it, a couple great pieces of federal legislation that was well intended had loopholes. Those loopholes allowed for very savvy business folks to exploit and operate under the radar and unfortunately hurt the rest of us. Well, where did it go wrong? 2003 was a very, very significant year. A very, very good federal legislation called Medicare D. Absolutely believe in the intent of Medicare D, which was, if you make prescription medicines more affordable for the elderly, can you then help prevent more hospitalizations and other big cost events? In other words, keep them healthier so they don't go to the hospital or fall down in an ambulance. Makes perfect sense. Well, at that time, they call legislative capture, which is a fancy way of saying lobbyist, came in, and the lobbyists between pharma and PBM said, hey, federal government, you're about to become the largest purchaser of prescription medicines in the world. That's a pretty big stick. Let us maximize that for you. Again, that makes perfect sense. Well, how are we going to do that? Well, to do that, we need to get a get-out-of-jail-free card. What do you mean by that? Well, there's a whole bunch of laws in the books that prevent kickbacks for anything the federal government spending, right? You can't play games. Well, guess what? There was a special exemption given to pharma and PBMs for Medicare D that allowed pharma and PBMs to basically do the most elaborate kickback scheme in world history. So 2003 was huge because it created the ability for there to be kickback games and non-transparent kickback games. So why didn't this go terrible in 2003? Like everything else, like this is kind of a newfound toy. What can we get away with in essence? And so then you get just a small handful of PBMs that get this big advantage, which allows them to be more profitable and buy up their competition to the point where now you have 3 large PBMs owning over 80% of the market. I think all of us know that if you have 3 entities that get to control 80% of the market, that's an incredible amount of power. And like all power, is that used for the benefit of the greater good or used for the ability to be able to make incredibly obscene amounts of money at the expense and detriment of others? Now there's so much overwhelming evidence that it's the latter. 2003, pharma and PBMs get this incredible advantage to be able to play a kickback game. Well then, roughly a decade later, Affordable Care Act comes into play. Again, great legislation, love the intent. We want more people into the healthcare system so we can help prevent disease and help lower overall health costs by getting prescription medicines or people into the system sooner. So where did it go bad? In order to get the big insurers on board, they had to have some assurances that they weren't going to get forced into a bad business model. So in essence, they got to be able to make 15 to 20% of their spend. Now, when I say that to folks, that usually is like, okay, I don't quite understand that. It doesn't sound good, but can you give me an example? Let's say that a patient needs to have a surgery. At hospital A, it's going to cost $10,000 to do the surgery. At hospital B, it's going to cost $60,000. Now, let's assume that the quality is the same. Well, every one of us would automatically gravitate to, well, if it's the same quality, we're going $10,000, right? No. If you are the CEO of a large health insurer, your sole fiduciary responsibility is to your shareholders. So if you can make 20% on 60,000 versus 20% on 10,000, you can argue that that's their job. So if you're a shareholder of those large companies, you're saying, hooray, good job, you found a way to make us more money, keep doing it. Now if you're the employer or the patient, you are appalled. Why would you make me go spend 60 grand when I could have spent 10? Well, you don't know about it, right? It's baked in your premiums. You have no clue this is occurring. So do health plans like PBMs who force the cost going up every year? Absolutely. If you can force a brand versus generic and force somebody to spend $100 versus 10, I get to make 20% on $10. If you can take a drug that's cost $60 and turn it into $7,000, I can make 20% on $7,000. And what we saw in the market is they not only liked them, they bought them. Because if you can be the health plan and you own your own PBM, you can basically manipulate your profitability multiple ways. And you get the rebates. So you get the rebates and you get to increase the spend and you get to pass it all along to the consumer. Now you're going to say, how do people get away with this, right? So if it's a federal government, of course, as if you're a taxpayer and you're on Medicare D, you have no choice. You're just giving what you're giving. Medicare D allowed for a special exemption for pharma and PBMs to create this black box of money. Affordable Care Act incentivized health plans to actually spend more. If you spend more and pharmacy is part of the spend, I like PBMs to keep raising prices, so health plans and PBMs then not only coalesce, they literally buy each other, they're owned by the same entities, and then take this extra money, what do you do with it? Well, you need to entice insurance brokers to peddle that, right? So pharma, PBMs, health plans, insurance brokers have this kind of four-legged stool that most of us folks that think we're just bound by. PBMs and pharma, because of rebate games, get to kind of play the shell game. They get the black box of money. What do they need to do to incentivize folks to talk employers into these health plans? Well, insurance brokers are the methodology that most people use to purchase a health plan. So now they can take some of these rebate dollars and says, I'm going to give it to you, Mr. and Mrs. Broker, because I want you to tell the local employers that our plan's the best. When you have this much money, you can make an awful lot of influence, especially as complicated as this is. And I bring that up because a classic is, whose fault is it? Everybody does this. And ironically, they're all part of it.
Yeah, this concept that really started in 2018, where we saw many of these large companies incorporate, so it's the PBM is together with a health plan, together with a mail order pharmacy, specialty pharmacy, and all of these entities are under common ownership. It was sold to the American public that if we allow this vertical and horizontal integration to occur, it's going to drive down cost and improve quality. Well, we're 6 years down the road and costs are spiraling upward. We are unhealthier more now than we were 6 years ago. So it is very obvious that when you put entities under common ownership, it allows them to create more opacity. It allows them to drive more profit to themselves because, yes, they get to decide what they pay their own pharmacies, and then bad things really start to occur.
People think that insurance is going to save them money, right? The Part D benefit was designed to, of course, help seniors get access to drugs, but also for them to get the benefit of whatever the discount. And the opposite has happened. But, in the healthcare field, the anti-kickback statute is a really, really important piece of legislation. And essentially it prohibits offering remuneration in exchange for a referral for something that's going to be reimbursed via federal dollars. By getting that loophole in the regulatory definition of negotiated price, that enabled PBMs to go negotiate massively complicated reimbursement mechanisms with pharmacies, independent pharmacies, probably the hardest hit, certainly retail pharmacies. It also enables them to go negotiate very complicated rebate contracts with drug manufacturers. And so ultimately, I think MedPAC looked at it in a 2023 report, and they looked at DIR fees. So about $12 billion in pharmacy DIR and about $50 billion in drug manufacturer DIR, meaning price concessions. So essentially about $62 billion of discount was deprived from beneficiaries at the drug counter. And again, these are America's seniors. Many of them are on fixed incomes. And the thing is, and the PBMs have this data and they know it, and this is what to me is so particularly egregious. essentially, they jacked the price up at the counter, made it really complicated using patient measures, and then deprived the patient of the discount. And what do we know about patient adherence? And PBMs have their studies themselves. The higher the cost at the counter, the less adherent to the medication the patient is. And of course, that impacts patient outcomes. That's how broken the system is. A patient is walking with insurance and it's costing them money. And not only are they buying a more expensive drug, a portion of their copay is going to pay the PBM. The sad part is the pharmacy lost money on the insulin. So the pharmacy lost money, the patient overpaid by a couple $100, and who wins? The PBM is plus $250, they didn't do a thing. The patient doesn't even know. What's a better business if you're a profiteer or a robber baron? Criminals understood what PBMs were. PBMs is what they would aspire to be.
We look at the benefit from a different perspective, which is what is the actual cost of the drug and build up from there, which is what's spitting out at the end. What's the actual cost of this stuff so that you can have a better understanding of what a guarantee should look like. I got hired at the Pharmacists Association, really still beginning the infancy of my career. That's when I got introduced to the complicated world of pharmacy, at least the money side of pharmacy. As a technician, I had no idea, really what was spitting out when I would help check somebody out at the pharmacy counter, right? In retrospect, the pricing at the pharmacy was a casino, right? Not because of the prices that were necessarily set by the pharmacy, but what insurance companies and companies called pharmacy benefit managers, which I didn't know at the time, how they were computing the prices despite what a pharmacy was charging. So my time at the Pharmacists Association quickly evolved into a government affairs capacity where I started to learn about the complaints of pharmacists, the complaints of patients, and public policy intersections with the profession of pharmacy. Within that role, I started to learn more about drug pricing as a whole. And what I learned, what I assumed is that pharmacists who are educated to a doctorate level now to know everything there is to know about a drug, its interaction with your disease state, how it works in conjunction with other medicines, and what I thought the business that governed the transaction. What I learned is that the expert that we trust to know the most about the medicine, including the finances of it, are actually passengers in the pricing vehicle, right? And to me, I found that to be incredibly compelling, that pharmacists who are supposed to be the experts don't actually have a relevant influence on what the prices are that are charged to an employer or a patient. And that set me off on a journey to learn everything I could about the proverbial layer cake that is a pharmacy transaction. When a grocery store puts an item on the shelf, they get to name the price. And if they price it too high, they won't sell a lot of that product. If they price it too low, that means they won't make a lot of money. So the beauty of traditional retail markets is that they respond very much to our wallets and our purses, right? The companies need to find this perfection equilibrium point of how much can I charge and still remain competitive, and also sell more of that product such that the end consumer will maximize the amount of value that goes to that retailer, right? That's why even though we might have publicly traded companies that are involved in the sale and distribution of milk, bread, eggs, cereal, you name it, their fiduciary obligation is to make more money. One would assume that in light of that, they would just charge $50 for a box of Cheerios, right? Well, they don't. The reason they exercise that restraint is not because they're do-gooders. It's because they won't make as much money if they overcharge for that product. So our impact as consumers is to create a sobriety around the prices that are being charged. All of a sudden, you go to that same grocery store, but go to the back corner where the pharmacy lives, all those traditional economic rules don't apply, because the pharmacy is not setting a price with the idea that a cash-paying consumer can afford it, because the cash-paying consumer no longer governs that transaction. And what I mean by that is that in the regular side of the grocery store, cash is king. The impact of the consumer and their wants and desires are what hold prices down. So the question then becomes, why is it that when you get to the pharmacy, those rules no longer apply and the prices are sky high. That's not a reflection of the pharmacy as much as it is who is the customer when it comes to the purchase of a medicine. And even though it is a patient who's walking up to that counter, today over 95% of prescriptions are being facilitated and transacted through intermediaries, health insurers, and pharmacy benefit managers who have actually taken the role of the economic pressure, if you will, on pharmacy prices. Now, what do we know about those industries? They're heavily consolidated. They have a lot more power than an individual consumer. So the question then is, if individual consumers are so effective at keeping the prices of grocery goods and all retail goods to a sober level, why is it that when you move to the pharmacy, the PBMs have been so unsuccessful in pressuring what would be a reasonable price commensurate with the underlying cost of that product? And the lesson there is that they don't actually want low prices. What they want are high prices and big discounts, which very well could be lower than what the marketplace would yield if everyone had to price their products reasonably. But PBMs make money not off of low prices, but off discounts from high prices. If I walked into Giant Eagle and the gallon of milk was $20, I would say Giant Eagle's ripping me off, right? So what will I do? I'll start, saying if the other things that I buy in my life are also overpriced, now I'm going to start looking at Kroger. Now I'm going to start looking at other grocery stores. I'll look at an independent, whatever it is. But what if, let's say, milk is too expensive everywhere? Let's say every grocery store was all of a sudden overcharging for that product. What would I do? I'd look for an alternative product. Myself as a consumer, the decisions that I make to purchase or not purchase creates pressure such that the milk supplier and the milk retailer all have to understand that in order to sell more product, they're going to have to be reasonable with the charges that I see at the end of the transaction. That does not occur in the pharmacy world, where the patient is often told, you have to go to this pharmacy, and at that pharmacy you will be exposed to this price. It is an atypical transaction from anything else we see in traditional retail environments.
Capitalism should work, and I do think the history of America has shown that. But when we think about capitalism, it has to be followed with transparency and access to true data. But in the PBM industry, nobody knows what their drugs cost. You show up at a pharmacy counter every single minute of every single day, an American does this, and they have absolutely no idea, first off, what it's going to cost. They have no comparison to know what it should cost. They frankly usually only know their copay or their portion, and we don't really know the greater cost of it that the plan or the corporation had to pick up. So capitalism totally falls apart, especially in the PBM industry, because nobody really knows these data points to make a better consumeristic decision.
Yeah, a lot of people, have, I think, a pretty negative perception of the oil and gas industry, right? The beauty of at least gasoline is that we have a tremendous amount of transparency into what the price will be. And we know and trust the price we see up on the big board, right, will ultimately be a reflection of traditional competitive forces. If I see that a gallon of gas is going to be $3.15 a gallon, right? Well, I can trust that I could probably do a search of every gas station within a 1-2 mile radius, and nobody's going to be around, $2, or nobody's going to be around $4, right? I can trust that competition is going to pressure prices in such a way that they'll ultimately be a reflection of reasonable competition. You look at the drug marketplace, that ain't the case. We're working on a study right now looking at Medicare prices, where we're looking at the different prices that are being charged within different plans where the drug program is run by the same PBM. And we found that for some PBMs, they have over 600 different prices for the same drug over the same time period. The range of the highest price to the lowest price can be the difference of $6,000 per prescription. Same NDC, same time period, same PBM, right? Different plans, but you're looking at 600 different prices with a range of as much as $6,000 between the highest and the lowest price.
And please understand, I get it. I know we live in a capitalistic society. I'm not opposed to anybody making money. However, in this case, they are ripping off the public, and they are causing prescription drug prices to be high. And they're not bringing any value to the healthcare system.
I feel like the more I hear, the less I understand. I mean, I just have one simple question. If somebody's covered by one of the plans, how is it possible that they've got to pay 10 times more than they would pay if they were just to go and pay out of pocket for the drug?
So on the one hand, we have PBMs claiming to reduce prescription drug prices. And on the other hand, we have the Federal Trade Commission. We have major media outlets like the New York Times. We have at least 8 different attorneys general, Democratic and Republican, who all say that PBMs are inflating drug costs. I wonder whom the American people should believe.
Today, Cigna Express Scripts, a Fortune 20 health insurance company and pharmacy benefit manager, announced that it was suing the Federal Trade Commission to redact the FTC's report on its price gouging practices. Why might Cigna be so embarrassed by this FTC report? Maybe it's because they don't want people to know that they're charging Medicare beneficiaries $3,613 for a cancer drug that costs $65, or that they're charging Medicare beneficiaries $3,534 for a multiple sclerosis drug that costs $10. I can keep going, but you get the idea.
You know, there was an article in the Wall Street Journal just recently about Gleevec. Gleevec was cost $55, and yet CVS was charging over $7,000 a month for that. Now that's robbery. And you know about spread pricing. We all know about spread pricing, about how an insurance company or a PBM, same thing, how they will buy medicine for $5 and charge $10 for it. And that's the spread pricing in that.
The PBM makes all the rules. Not only do they get to decide what they pay themselves, they get to decide where you have to get your drugs filled. So there's numerous examples out there in the literature where imatinib would be my favorite. So there was a product called Gleevec that was on the market for years and years. It's an oral cancer drug. It's gone generic. The generic is now called imatinib. You should be able to get that from any pharmacy in America. You can go to a community pharmacy. You could get it from mail if that was better. But what the PBM does is they say, well, it's for cancer. Therefore, you can only get it from my specialty pharmacy. And we've seen instances where this drug should cost about $600 to $700 a year for an entire year of therapy, where employers are getting charged $212,000. $212,000 is what a year of this costs from a specialty pharmacy that's owned by a PBM. For the same drug, you should be able to go to your community pharmacy down the street and pay $600 or $700 for.
The PBM that is, dictating essentially what the reimbursement is going to be for the pharmacies via take it or leave it contracts. And then on top of that, they are massively manipulating the price of a drug. And why would they? There's different reasons. If you're in a state plan where there's spread pricing, as that's traditionally defined, meaning the pharmacies reimburse low and the client is charged higher, and the patient walks in the door, that patient is going to pay that drug price at the counter is going to be low, probably a lower cost share as well. If you're patient, same disease state, same day, you're a senior, and it was a situation where the PBM could jack the price up and then take it back from the pharmacy after the fact, that same drug may be massively more expensive for a senior in Part D than it was for somebody in a Medicaid managed care plan, right? So they are arbitraging that drug price, once again, familiar theme here, to their advantage. Literally as blatant as you could, steering thousands and thousands and thousands of patients into their own channels, and then they're jacking the prices up, and they've gotten away with it.
Give us the truth, the whole truth, and nothing but the truth, so help you God.
Your companies steer patients to affiliated pharmacies, yes or no?
The answer is no.
Dr. Koster?
No, sir.
Dr. Conway?
No.
They're under oath to tell the truth, and they lied. They said there's no patient steering. We know better. We know better. We had pharmacists there. It was the room was packed, and they just outright said, "No, we're not steering patients toward our own pharmacies." Well, we know that's a lie.
they are absolutely brilliant at misdirection. They will tell a fraction of the truth and even sometimes blatantly lie. So at the House Oversight Committee, they were asked point blank, do you patient steer? And on film, all three said, no, they do not patient steer. I believe that every single independent pharmacist that watched that had their jaw dropped to the floor saying, how could you possibly have the gall to say that, and why isn't your nose growing, and why aren't your pants on fire? Because we've experienced literally dozens. We've had our patients get letters saying, you can't go there anymore. We've had folks come in crying saying, I just got called, says I can't come here anymore. Heck, on government websites, you can't go there. You have to go mail order. We've literally had a case where a patient filled a prescription, was still in our pharmacy when the patient got a cell phone call in our pharmacy asking the patient, why did you go there? Why didn't you go to the one they wanted you to? And then actually chastise the patient for not going there, and then actually give us a call afterwards, says if we do that again, we're going to kick out of network. So I mentioned fear of retaliation. That is real. Most folks won't believe the following, and it has been illegal, even though most folks don't even know. It's called a gag clause. So the patient comes in, and the latest scam is some of these cards. Hey, I got a card, and if I get this, I get a better deal. And we're going, yes, but you have no idea that if you just ask us our cash price, we're always going to be better in this deal. Well, then why aren't we transparent with our cash price? Because we can't, because we can actually get kicked out of the network if we are actually telling people that they can get a better cash price than their copay. So literally times where a patient can come in and their copay might be $50, and we'd say if you don't run through insurance, your cash price would be $20. I mean, it's hard to fathom that could be true, right? Like, who would ever think that would be normal? Because that's you think that the insurance company is on your side. So they don't realize that the $50 copay, they're actually pocketing $50, paying us $15 for a drug that probably cost us $13. Right? So we're happily sell it for $20, save the patient $30. We actually get a margin that lets us pay the light bill versus that $1 that gets us out of business faster.
It sounds crazy because there's few other business models that would do it, right? There are pharmacists every day that are dispensing life-saving drugs to patients who have governmental insurance, federal insurance, and they're losing money. Sometimes it's $1, sometimes it's $100, right? They're losing massive amounts of money, and they're doing it over and over and over again. Absolutely furthest thing from the truth. Pharmacies do not set their own drug prices. Those drug prices are set by pharmacy benefit managers. These are people that, again, mainstays in their community and that go above and beyond every day. And sometimes they do it at a loss. You know, how many independent pharmacies have showed up on a Saturday night and opened up the pharmacy, or are willing to go and deliver to folks in a rural area because there's just no other access, right? These are not people who are looking for massive money grabs. And I think we're getting close to the time where PBMs saying, hey, we're lowering costs is almost as laughable. Certainly if you're in the business and you know that they're having these 47,000% markups, right? It's a laughable claim. But now we're talking about healthcare. We're talking about access to life-saving medicines. And we're talking about taxpayer dollars. When you dig in, when you look under those rocks, everything you see is problematic and unscrupulous. And so, does it reach the measure of unfair methods of competition under Section 5 of the FTC Act? I think so. I'd welcome that conversation with anyone, right? Because they are implementing incredibly complex methodologies, all sorts of secretive contracting, doing it to the detriment of patients, of pharmacies, of their clients, and taxpayers. And they've grown fat doing it. I believe this is true, and I believe that ultimately it'll happen, right? Pigs get fed, hogs get slaughtered. And I've seen no greedier business model than PBMs in any other industry. I think they take the cake.
Pharmacists, most accessible healthcare professionals in America. We got to keep those going. I know they're hanging by a thread now, and they are. They are hanging by a thread. I hope they can hang on, because I'm telling you, we're very, very close. We've got our hand on their throat, but we can't let it off, and we've got to finish the drill. If we can do that, then I assure you, our healthcare system in America will be much better off. It's an unlevel playing field. Timing's everything. I was very blessed and very fortunate when I came into the profession, because PBMs were just processors. All they did was process prescriptions. They didn't have formularies or anything like that. And all you had to do was be nice to people and take care of them. And you were successful. And then it evolved over time. All of a sudden, PBMs discovered that, hey, there's a formulary here in this hospital. If we can have an impact on that formulary, and then we can capitalize on it.
Formulary.
The formularies. That's
changes.
that's the biggest thing with Cole right there. His formulary changed on his discus, and it was moved from a tier 1 to a tier 3, which put it up at the higher price point. You know,
complete lack of transparency.
Yeah, they didn't tell us they were doing it until we walked in the pharmacy.
The PBM would say, what's it worth to you to get access to my lives as a PBM manufacturer? So then the manufacturers have to pay these rebates to get their drug on formulary, knowing whichever one pays the most gets on formulary, the other one doesn't get access and sell any product. So it used to be that the formulary, I think, was a true clinical reason to make sure that manufacturers were bringing high quality drugs to market that benefited the PBM's membership. But the PBMs have evolved this, frankly, into an aggressive profiteering engine to make sure that manufacturers are competing against each other for profit purposes, and then they're just extracting as much money as they can, keeping a substantial portion of these dollars that manufacturers give, but then tell the American public and corporation, hey, I gave you all these rebate dollars, you're welcome, I used my size and scale to buy down the cost of your drugs, but frankly, in my opinion, always in a way that's not helpful.
I think almost everybody's heard of a monopoly. A monopoly, only one show in town, the only one selling it so they can make their prices. And we already know that history, monopolies are bad because they can basically hold entire economies or societies hostage, right? That's why there's laws. Sure, you can't do that because you can't rip off all of society. But most people haven't heard of a monopsony. A monopsony means I'm the only one that buys this, right? So if I'm the only one buying carrots, and I get to buy all of them, now I kind of have a monopoly de facto because I'm the only one selling it. So now we go to oligopoly and oligopsony, okay? It's the same thing, but instead of one, it's three. So if there's three of them, hey, we're not a monopoly, but there's three of them that basically I own 80% of the market selling them, and I get to purchase the drugs. Let's go to asthma inhalers and insulin that we all know has been around for a long, long time, and a great number of people around. That's where we're getting ripped off the most. To have an insulin going to $290 to $594 where people can't afford it and they die, that's manipulation, that's gross. That's the opposite of what healthcare is supposed to be, but it is today because there's only three players, and you're a manufacturer, and you're going, I have to get on their formulary. Because if I'm on their formulary, at least I got a third of the market, so what will I do to get on the formulary? So in other words, you almost have to bribe them to be on the system. New York Times had a brilliant article that they did a deep dive expose that proved that opioids, as we now know, opioids are extremely addictive, absolutely ravage families. I believe 15% of people who are on oxy once become hopelessly addicted for the rest of their lives and will do anything they possibly can, which damages communities, families, livelihoods, creates carnage. And we've seen around the country. To get to be where they were, the New York Times article basically states that the manufacturers of this paid extremely large rebates to get on formulary for PBMs to carry it. So the very people, to really put this in perspective, to be in the formulary, companies are hiring people to say, do my formulary for me, assuming that you're doing it, for lack of a word, for the right reasons. In healthcare, there is an inherent expectation that people are there to do the right thing by you, patient. We're at the most duress of any point in time, right? If you're in the emergency room, you're not thinking straight. You're thinking about trying to either survive or overcoming something that's incredibly traumatic. That's not the time you want to be asking people 100 questions, says, can I trust you? And nor, when do we pick vendors to give our health plan, there's an automatic assumption that you will be doing the right thing. So it comes to a formulary, you're kind of saying, well, of course, you're going to do the right thing. But now to find out that formulas were actually managed such that you took incredibly large sums of money to keep on something incredibly addictive, and this inflamed the carnage that occurred, is just absolutely unconscionable. So when the FTC announced they were suing the big three for insulin manipulation, it was like, it actually renewed hope.
I think insulin's a great example here, right? You have a patient that is life dependent on insulin, and what have we learned? That insulin is unilaterally too expensive across the board, driven by a number of factors, most notably a growing disconnect between the real price and the list price of that medicine. If I was a diabetic, I couldn't just simply say, well, no more insulin for me today, right? That's a fast track to death. So the reality is that the patient is often a captive consumer because they don't have choices to just delete their diseases, right? Or decide, hey, I'll take a medicine that doesn't actually help me. So there's a tremendous curation, if you will, of choice because we as patients need what we need. So despite the fact that insulin was clipping at $35 or $40 after you tabulated all the discounts, many patients would walk into their pharmacy and ultimately get charged $300 or $400 for that vial of insulin. So let's spell this out like very simply. All right, insulin's list price was around $300 or $400. After all the discounts the drug company gave up, that product was actually only valued at $35 or $40. Yet those discounts weren't flowing through to patients. Instead, they were floating to someone else. So I'll use an analogy here. Imagine if you were a consumer and you were in the market for a new dishwasher or a washing machine. Most of us are familiar with a rebate in that sense, right? Some are priced, as is. Some products might have a rebate. And after you sit down and look at all the different options that are available to you, you all of a sudden decide that a product that has maybe a $1,500 price but a $300 rebate, that's the right one for you. So you walk up to the cashier, you pay the $1,500, you fill out the form, and voila, a rebate comes back to you. If for whatever reason you sent in the form for that rebate, and let's say your neighbor were to grab the check out of your mailbox, that would be them stealing from you, right? You were overcharged for that product. If for whatever reason the manufacturer chose not to send you that rebate check, that means you were overcharged for that product. So in traditional retail settings, we understand what a rebate is. I overpay to get some value back that lowers the net cost that I incurred for said product. Again, not in the pharmacy world, where a sick patient who's already saddled with a lot of medical bills and other sorts of diabetic supplies that they need to keep up with their ongoing disease management, walks up to a pharmacy counter and is told by their insurance company or their PBM that you will be charged $400 for something that is generating hundreds of dollars in rebates, that is going back to the very company that has told you to overpay for that medicine. So if you're a patient, you walk up to that pharmacy counter, you're paying $400 for something that your insurance company might be getting $350 back from, right? So you, the patient, are the one that is the origin point of that rebate. In our world, we call that money from sick people, where a sick patient overpays for a medicine that generates a rebate that is ultimately collected and harvested by somebody other than the patient who had to foot the expensive bill in the first place. In a simple way of characterizing it, when you overpay for a medicine and it generates a rebate that goes somewhere else, that somewhere else is usually the PBM. The pharmacy benefit manager is a large company that ultimately determines which drugs will be covered under your benefit plan and which ones won't. Because of that, because so many of us are getting our medicines through insurance, drug companies have a big vested interest in the decision-making process of PBMs, and thus are willing to cough up big bucks in exchange for opening up that market access. There was a report released just this year, 2024, by the Drug Channels Institute that quantified the value between the list prices of medicines and the real prices of medicines after all those rebates are accounted for, that gap has now reached over $330 billion. $330 billion of fluff that exists between the sticker prices and the real prices of medicines after all the discounts are tabulated. The interesting thing is that everybody's been very upset about the prices of insulin over the years, for good reason, right? We know very well insulin's origin story. It was essentially a patent was given away for almost nothing, with the idea that this is a true public service, right? This is something that people really need. Now, it's unrealistic to assume that a bunch of manufacturers are going to grab that patent and essentially start making insulin for free, right? There's costs associated with that. And furthermore, publicly traded companies have to make more money. Regardless, we over time saw a good amount of competition in the insulin space. We know brand companies that don't face competition, they're going to be able to charge whatever they can get away with, right? The idea from an American perspective is that we've granted a patent, and if you as a drug company bring something new and innovative to market, something that didn't exist before, you have the right to charge essentially what the market will bear, because we want to reward you for bringing something to us that is materially better than if it wasn't on the market before. So that's the trade-off, right? We want manufacturers to bring us cures. We want manufacturers to bring us things that make our lives better, continue our lifespans. And so we give them incentives through patents such that they have the right economic incentives to do that. Insulins are a great example. We have 3 big manufacturers that offer comparable insulin products, one versus another. In that instance, those companies can't necessarily take the liberties that are provided to somebody who has an orphan drug, if you will. So what do we know about competition in all other, economic marketplaces? Is that competition works to increase quality and lower price, or some intersection between the two. So with insulin, what you saw over time is that rather than competition working to lower the prices of those products, insulin manufacturers competed to raise their prices almost in lockstep with one another, while simultaneously increasing the amount of discounts that were provided to payers in the marketplace. Now, some of that is driven by government programs who mandate that they get massive discounts off the list prices of medicines, but a huge component that was driving the disconnect between the list price and the real price of insulin were big rebates that were offered by drug companies to PBMs in exchange for preferential treatment on the formularies, where the PBM decides which drugs will be covered and which ones won't, which ones will be preferred versus which ones won't. So what you saw was not a race to the bottom on the price, you saw a race to the top. So you saw something that was $10, $20, $30 decades ago turn into a product that became $300 or $400 over time. Now the drug company, what we found from Senate Finance Committee investigations, as the list price went up over time, you actually saw diminishing returns for the drug company. In fact, what you saw was that after you tabulated all the discounts that the drug company was passing through to government programs and to PBMs in the marketplace, the actual underlying cost of insulin was going down. It doesn't just impact them from a financial perspective, right? Although that financial perspective is big deal. We have seen patients who are making trade-offs all the time in order to keep themselves well. They'll decide to ration their insulin. They'll decide to forego diapers, groceries. They'll decide to forego other things in their life in order to afford the very thing that keeps them alive. Unfortunately, I'll rewind the tape back to when I worked in pharmacy as a technician. I used to see instances where if you told a patient their copay was $5, there are some people where that is unacceptable and untenable. I've seen many patients leave a pharmacy because a $5 or $10 copay was just not within their budgetary availability. Now, when you think about insulin and how life dependent it is and how many people it impacts, right? We're not talking about the difference of $5 or $10 at the point of sale. You're talking about hundreds of dollars. where people will make decisions that have, in many instances, has caused them to go to the hospital, incur other sorts of losses in their life, or to actually, worst case scenario, die from that problem.
A group that tracks drug costs says about 60 companies increased the price on almost 300 medications. The price of insulin, a life-saving drug for diabetics, tripled between 2002 and 2013. Since 2008, 3 top manufacturers raised the list price of insulin at least 10 times. Anna Werner shows us one state's plan to rein in soaring costs and one mother's personal fight.
My son died because he could not afford his insulin.
Nicole Smith-Holt's son Alec was 26. He had just moved out of his parents' home and was starting a life of his own.
The hardest part is every time I tell the story, it's like reality slaps me in my face that my son is no longer here.
People are dying because they can't afford their medication, and you all are part of the problem.
The answer is simple. The dominant 3 PBMs put stock price over health. Well, I can go on and on and on about the big 3 PBMs. They are everything that is wrong with this industry.
The big 3 PBMs are CVS Health, OptumRx, and Express Scripts. The influence of PBMs recently impacted a Wisconsin family.
Our own Shauna Johnson has more on the tragic story and the fight for more regulation of PBMs. Shauna?
A bill to regulate pharmacy benefit managers never made it to vote in the Assembly, but families and independent pharmacy owners from across the state say legislation is needed to save lives. Unfortunately, it's already too late for one Wisconsin family.
Yeah, I don't want anyone to ever have to experience this.
Our son Cole was 22. Essentially, when I was pregnant with Cole, we knew he would have asthma because Bill and I both have asthma. Our doctor had said there was a better chance of this baby having asthma than not. So we were prepared. He was officially diagnosed, I think, probably around 18 months. I remember as a baby him having, the little inhalers with the chambers back in the day. That he had a yellow one with bears on it. I can remember.
Oh, yeah.
Kind of grew up knowing what an inhaler was, how it helped him. There were plenty of ER visits where he would struggle in certain seasons, or when he was, I don't remember the exact age, but maybe preteen, he was prescribed a daily steroid medication. But actually, we both were prescribed it as well. And I always say that that was life-changing for all 3 of us. Cole was able to play sports. He was able to live a normal life. He had that discus every day, and he was good. He moved out on his own probably about age 20. He had moved in with his childhood best friend up in the Appleton and Green Bay area. He was doing well. Cole struggled for many years with school issues, ADHD, severe depression. So it was really great to see him go out on his own and finally find his people in the world. He was finally happy and doing well. He was working full time and just happy. It was amazing. He had texted us on a Monday and was having trouble breathing. He had texted Bill. He was trying to use his nebulizer, which again is something we had for years at the house for times when he needed it. And he was texting Bill that he was struggling with the tubing or whichever. Bill had told him, I can drive up, whatever you need. I don't know how to help you over the phone. I'll come up and see you, whatever you need.
About 45 minutes later, he had actually called me. And his biggest concern was, what insurance do I use?
To go to the ER.
Yeah, to go to the emergency room. Because I could hear his labored breathing. I mean, me having asthma, I could tell exactly where he was at in his asthmatic attack. And I just get chills still thinking about it. Get to the hospital. I knew there was one close. I said, call an ambulance, do whatever you need to do to just get there. Just go to the hospital. Don't worry about insurance. He had told me that his roommate was actually at the house that evening. He drove him to the emergency room. As soon as Cole hit the cold air outside, though, it was 22 degrees below zero roughly that night. It was one of those deep freezes in Wisconsin, and that really triggered his asthma.
The emergency room was like 6 or 7 minutes away only.
There was a lot of ice on the roads. On his way there, his breathing got worse, and he actually went unconscious in the car. Yeah, Mitchell had grabbed his hand and was trying to feel a pulse the whole way there. At the last minute or so, he said that there was no pulse. And when Cole did arrive at the emergency room, he was lifeless. They had to resuscitate him to bring him back.
We later found out that he had suffered a cardiac arrest in the car, is what we assume had happened, which is why Mitchell could no longer feel a pulse.
As we got a message from Mitchell, I actually got a call from the doctor in the emergency room, and we did drive up, got up there about 1:30 in the morning,
and the doctor had told you he was on a ventilator at that point in ICU. So we knew it was not good. I remember packing up a bag, because, you just think you're going to be gone for like a day, because it'll be fine. And I was like, this cannot be happening, this cannot be happening. I just kept repeating that over and over and over. He had asthma for 21 years. I just kept telling myself, like, what is going on? Because again, 21 years of managing his asthma, he knew how to manage it. I did not understand. But we took Bill and I and his brother, who had just turned 17 at that time. We got in the car, and horrible road conditions, icy January night. I just remember so freaking cold and icy on the roads. But, you remember like every detail of all those days. I remember every detail. But we walked in. I remember Bill pushing the button on the ICU floor or whatever. And I remember Bill saying, like, who we were and we're here to see our son. I just was no. And walking in and seeing him on that ventilator, we just...
Yeah, it was just, I mean,
it's unreal. It's like a night. I mean, it is a nightmare. It still is a nightmare.
When they went to resuscitate him, they couldn't even get a tube down his throat because
his airway was so closed. And Joel had told us, you're going to be in for the long haul here, so get comfortable. There were concerns right from the get-go about brain damage because he had gone an unknown amount of minutes without oxygen. Mitchell, his roommate, who just holds like such a special place in our heart because he was with him for those last minutes, did his best to be a reporter. And here he's 20 trying to give details of the worst probably night of his life, his best friend dying in his car. So they had very scattered details, and that the next, I think they had said 36 to 48 hours were crucial at that point. But Cole ended up being in the ICU for 6 days. Those were obviously the worst 6 days of our lives. We went from, hey, we see some hope, there's a little bit of brain activity. I remember him telling us, like, you're not going to get the Cole back that you knew. But we were like, that's fine. We'll take him however we can have him. And so they're like, okay, we're going to keep monitoring. He was so heavily sedated, obviously still on a ventilator. And then the next day, that Dr. Long would come back and say, he had us standing by Cole's bedside, I remember. And two of the most amazing nurses were behind us. And I just remember Dr. Long, saying things like what we thought we saw, the hope we thought we had, starting to and I remember we grabbed hands, and I remember the nurse pushed a chair up behind me because she knew we're going down. And we did. Because he just said, like, there's no hope. This is it. He's going to be ventilator, feeding tube dependent. This is what you see this is all you will ever have of your son.
It's a blur, but I remember just collapsing right in the bed.
Yeah, you collapsed on his chest, and we couldn't believe it. Like the day prior, we had just a glimmer of hope. That day, we started to have conversations about end of life. They had told us that Cole was an organ donor, which we did not know. So we're super proud of him for that. I know it seems dark to be joking about stuff, but Cole was such a quirky kid, and I can literally picture him at the DMV being like, do you want to be an organ donor? And I imagine him being like, do I have to pay for that? And if it's free, then sure, put me down. All these other families are getting the best phone calls of their lives that an organ donor is available for them, and we're told, oh, Cole has, amazing organs. Well, no shit, he's 22 years old. Of course he has amazing organs. This isn't supposed to be happening. The only thing they said he couldn't donate was his lungs because they were so hurt. So on Friday of that week, we had our family come and say their final goodbyes. By By that Sunday, the hospital did an honor walk with us for him to the OR, and he donated what he was able to donate, and Sunday, January 21st, he passed at 10:06 p.m. Even at the ICU, his roommate was there, his best friend Mitchell, and so he was like our only kind of source of like what the hell happened. And it was Mitchell who told us he was out of his medicine, and we're like, what? Like, how? Why? How? And Mitchell had said, yeah, we went to the pharmacy. Mitchell had gone with him because Mitchell was picking up something as well. On the Wednesday prior, Mitchell said, yeah, we went to the pharmacy. And he said, I don't know, Cole went up to the counter and came back and showed me on his phone that it said $539.18. And Cole was like, I can't afford that.
That same medicine for a 90-day supply last year was like $70.
When Mitchell told us that, we were like, what? You know, again, like your mind just starts spinning like, no. Like he must not have given him his insurance card. Like there had to have been a mistake. Like this cannot be. So we had that's the only little piece of information that we had that could have led to this. We didn't know how, why, what brought us to that $500 price tag, and within a matter of 5-6 days was in the ICU. And still just not knowing.
That was tough, and the way we found out about it was kind of
a fluke.
Yeah, fluke.
Yeah.
Well, I have asthma, like I had mentioned earlier, and Shannon was in town with one of her friends in a small town by us, and I asked her to swing by a pharmacy and get my discus. I get a call from her saying that my discus isn't covered anymore, and that the pharmacist was, however, trying to find something else, and the pharmacist there wouldn't let her leave.
Yeah, I remember her, she specifically said, I'm not letting you leave with nothing. And it was then, that I kind of was like, wait a minute, this is sounding eerily familiar, right?
Yeah.
Bill and Cole worked for the same company. They had the same insurance. So literally everything was the same medication, everything. And I was driving home, and my friend Christine was like, what's going on? And I'm like, this is what happened to Cole. Like, this is it. He just, A, didn't know to ask questions. He was 22. But B, he went to a pharmacy where the pharmacist didn't take the 5 minutes like Bill's did to say, whoa, wait a second. Like, you need to breathe. So let me figure this out. They were like, well, it's $500. Like, you got that or not? And Cole said no. And that was next in line. And yeah, I remember so vividly sitting in my friend's car, like my mind again, just spinning like, holy shit. Cole, this is all it would have taken? Like, are you kidding me? This is all it would have taken for Cole to have gotten his prescription that day? This cannot be okay.
And obviously the clarification on this is Cole went to a chain pharmacy that's very large,
understaffed,
possibly, very heavily involved with PBMs at times and whatnot. And I chose an independent pharmacy, and there were two drastic outcomes.
Drastically different outcomes.
Mm-hmm. Yep. Well, the pharmacist agrees with us, what we were talking about over the weekend. We think that something shady happened. We'll just say that. I think that was kind of contributed to Cole's death. I mean, there was an outside factor that did it. And that was Saturday. I get a call about 3 or 4 o'clock on the Monday, and that's, I think, kind of when our world really just when holy shit, something really did happen to Cole, and we got to do something. That pharmacist actually called me and wanted to introduce me to you, Dan, and knew your mission.
We had a call from one of our pharmacists saying that one of her patients, Bill and Shannon Schmidtknecht, had a tragedy. And they're just starting to learn about PBMs. Can you reach out to me just to be able to help fill in the blanks, just help them through this time? Well, of course. That's what independent pharmacies do. We take care of folks. So I got invited over, and I got a chance to sit in the kitchen table with Bill and Shannon, and that is, I'll say, 2.5, 3 hours that changed my life, that made this, that we have to do this. They had the ultimate tragedy that should never, ever occur, and created incredible pain. for the family and for almost everybody they touched. So I made it a point to myself on the way from their home back to home. I called up my daughter's a filmmaker, says, Mary, you were right. We have to make this film. This has to be done, come hell or high water. Because people are dying now. We knew it was going to happen, but now it did. We didn't do enough ahead of time to prevent this, and we're not going to let this happen again. And legislators, I don't care if you don't understand it, or you don't have enough backbone to fight it, or you're getting paid too much. Enough of that. We're going to make enough people know what's happening that hopefully the rest of society comes and says, this is enough. We've seen so many terrible things happen in the last 6 months that shouldn't happen, but they have because so many people are hurting. And they're hurting because they're getting extorted, they're getting ripped off, they're getting manipulated, they're going bankrupt because they shouldn't. Because 3 parties have gotten so damn greedy that they're taking the rest of us for a ride. And now that we know what's happening and that it can be fixed, we have to do this. And I think the reason why we didn't do it sooner, people are scared. If you are a pharmacist or a doctor, you are scared for fear of retaliation. The name of this movie, Modern Medical Mafia, wasn't by accident. I'm a fan of movies. And when you watch things like Godfather, and you watch documentaries, the mob of the 20s, you think of what must have been like to be that shop owner in New York where you had to pay protection money. How horrible would that be? Then I woke up one day saying, holy crap, we're it. We're getting started every day. We get all these fees and manipulations, and then we're scared to say anything because if we do, they kick us out of network and we can't serve our customers at all.
State of Ohio, the Attorney General sued Express Scripts because of the spread pricing that they were doing on the state Medicaid program. And he referred to the PBMs as gangsters. That was his words, not mine, but he referred to them as gangsters. And what they're doing is what gangsters do. They are ripping off the public and not bringing value. Now,
it's a modern form of barely legal gangsterism.
We pay more for prescription drugs than any major nation on earth.
And you know, what I would say is, like, the Mafia is small ball compared to what PBMs do. The scale that PBMs do it, the brazenness that they do it, and the sophistication. And what they do is, you know, they're able to entwine themselves with agencies at the state and federal level to such a point, right? To such a point where they can control regulations, they can control the way agencies look at regulations, the way they look at practices, and they can pave the ways, right? So it's like akin maybe to a mafioso paying off an individual police officer, right? But again, it's not, hey, we're paying them off in this case, but you know, they've got professionals and they're constantly interacting with these agencies, they're lobbying the agencies, they're advocating the agencies, they've got contractors that work on a daily basis. And what happens is the very folks who are supposed to be watching, instead of looking out for the public interest, they become really, really sympathetic to the point of view of the people that they're supposed to be regulating. And so they are able to work with agencies in a manner, right, that like they're oftentimes writing their own regulations. From my perspective, you know, the Mafia is down here and PBMs are doing it at a whole nother level, right? The Mafia wishes they could be a PBM, right? Where, you know, they found a way to monetize and suck literally taxpayer dollars, but they've got like a funnel directly to the source and they're just sucking the money out.
There is no difference in my mind. PBMs are strong. They're powerful. A lot of money, and they spend a lot of money.
But I think as we've really found out over the last 5 years, PBMs aren't trustworthy in general, especially the large traditional ones. If costs of drugs are going up, if people can't afford their drugs, if we're getting sicker as an American population because of all of these bad PBM decisions, and we simply say, PBM, give me the data to prove that you're doing what you say you're doing and helping out, and they don't give the data, what does that tell us? These PBMs have just been so emboldened to do whatever they want that they don't care, because who's going to prove it wrong, who's going to bring it to court, and who's going to hold them responsible? So they just keep doing what they're doing. A lot of the laws that are written is if the PBM violates the law, they're going to get a penalty of $10,000 a day. So $10,000 a day to an entity that's making tens of billions of dollars a year. That's $3.65 million a year. That's $36.5 million for 10 years. So I would be a good steward and say, hey, federal government, here's $36.5 million. Here's my next 10 years worth of fines. You're welcome. And I'm going to keep making my tens of billions of dollars a year. So even if they do get caught, the fines are so nominal they don't care. As an extension to the mafia, drug cartels. I think the drug cartels are more transparent than PBMs are. Let's just be real clear. You know what you're getting out of the Cali cartel, full stop. Nobody needs to guess. You have no idea what you're getting out of CVS, Optum, or Express Scripts. Because there's no data, there's no proof point. They continue to hide and obscure things. Let's face it, their chief executive of each of these companies were just in front of Congress, and Congress is calling them out for perjuring themselves and lying to Congress. So if the first time is a public, we get to see these guys get questioned by Congress and they lie to them, what are they doing to everybody else?
I'm just appalled that Cigna Express Scripts had the arrogance to sue the FTC to redact a report. I mean, tell me you're guilty without telling me you're guilty, right? To ask the facts to be taken from the record.
There are people literally dying because they can't afford their medicines. There are people literally going bankrupt because they can't afford their medicines. We've been almost conditioned as a country, well, that's just the way it is, but we've never asked the question, well, how much does it cost to make? How angry are people when they realize the cost to make a drug is $16, but they're getting charged $7,000? But when it comes to medicines, like, this isn't about luxury, this is about potentially life and death. That should not be an area we get it started. It's not an area we should be manipulated or blindsided or black boxed.
Oh, I firmly believe it's like a mafia.
Yeah.
I mean, like,
people keep saying, like, you can't make this up. Like, that's how I feel.
Extortion or the strong arming or whatever it might be. I mean, like, that's what every little tactic appears to be.
They have you. We need to breathe. The MS patient needs to survive to function. The diabetic patient needs insulin to survive. The list goes on. And
like you said, there's just so many angles they come at you. Makes me wonder if the pharmacy Cole walked into. But then I learned they don't set the pricing. The PBMs do. The only person to give me a price on Cole's medicine, the price went up, has been a PBM. They read it right off their screen what they told the pharmacy to do. So that's what we've learned, is it's all greed. It's all greed. Greedy, profit, but deceptive, non-transparent tactics. I mean, like, that's if you had to sum up the PBM, that's the best way to say it.
This might be an odd time and place to say it, but we actually need pharmacy benefit managers in our health system. They serve a necessary function. And here was what that function is formulary management and enforcement. And it says at its very core that they create the suite of options of therapeutically equivalent drugs that a patient can access when a doctor says that they need medication for a condition that they have. And the reason that formulary management and enforcement is important is that if it didn't exist, the pharmaceutical manufacturers would be price gouging on drugs. What makes the US biomedical system work is that a pharmaceutical company manufactures a new drug. They earn a reward for that research and development. But then after a little while, it goes generic, meaning that competition comes onto the marketplace. And what you see in charts of US drug prices is that after it goes generic, the price plummets. And this drug becomes quite cheap, actually. But for that brand to generic cliff to happen, you need somebody to tell the pharmaceutical manufacturers, no, we're going to go with the generic instead of the brand name drug. So I want PBMs doing that. The problem is they took that pretty simple premise, which is like a line of software code. If A, then B. They took that simple premise and they decided it was a $300 billion enterprise, and they got greedy. And so they're now the ones who are rent-seeking and extracting and price gouging, and they need to be held to account.
So we have been manipulated and extorted more than people can possibly believe. So it's like, okay, enough. This has to be done. It's amazing how many incredible people across the country are fighting the same fight. It's not just us. As we reach from the country, there is an army of independents and patients and patient advocacy groups and physicians, folks who actually give care to patients, who are all saying we've had enough.
Where people do need to lend their voice to their federal policy leaders or their state policy leaders and say, no, we've been talking about why drugs are unaffordable in America for 30 years. And this is the definition of insanity, right? Doing the same thing over and over again and expecting a different result. We allow the PBMs to own and control all aspects of the pharmacy supply chain and what we pay, and costs go up. And they have every year for 30 years. So if we continue to allow that to happen, what's going to happen in the next 30 years?
We've got them on the run. But now let's face it, they're big companies, big corporations. You know, number 4, 6, and 16 in the top 25. They're not going to go down and just lie down without fighting. They're going to fight hard. But I really do think that, you know, transparency is going to be the key. If we can show what's going on here, then I think there'll be a call for changes.
Yes, right. I've been in rooms where there's 2 independent pharmacy representatives and 30 to 50 PBM, insurance, and managed care lobbyists and attorneys in the room. And pharmacists are tackling that issue in state capitals, and they're winning. They're winning. And that is, I really can't think of a parallel, right? It's an incredibly powerful story to tell now. And I think, you know, from a historic perspective, looking back, retrospective, there's going to be lessons to learn, because very rarely will you have like small grassroots Main Street interests be that successful against massive corporations. And I think we're getting close to the point where a PBM can't sit there with a straight face and say we're lowering prices. We're using our capacity as a drug benefit administrator to lower costs for clients, to lower costs for taxpayers, and to lower costs for patients. Because over and over again, when you look under those rocks, you see the absolute opposite, right? What you see is they are engaging in practices to drive those costs up. It's not often that the patients tell the story, but when they do tell that story, it absolutely is heard, and it can absolutely compel action and change.
I think it's a matter of as many people and as loud as we can be is the goal. So 5 people to 5 million people, 5 postcards to 5,000 postcards, just being as persistent and as loud as we can possibly be so that our lawmakers have no choice but to hear us.
Yes.
No human should not be able to access a medicine that is prescribed to them by a physician.
Our story is a tragedy. We live that every day. We know that someday we'll bring justice for our son. I like to say the word justice. And not only for him, it's going to be for everybody. And this affects everybody. And we want to fix this so no one else dies. That's what we want to do. Yes, we've suffered our tragedy, and I don't want this on anybody. And if people don't get involved, they don't get loud, this is going to continue. The PBM reform mission is real, and it affects everybody.
You would have loved him. He was a cool kid.
Right here, this is where it all happens. The circle of death.
It's almost like murder in a way.
People who could die as a result of being refused care because these companies choose profit over people every time.
They just are destroying independent and community pharmacies.
We can't stay in business being paid less than our cost.
Because PBMs are allowed to set my reimbursement rates. I made more money on a regular cup of drip coffee than on 40% of the prescriptions I filled in 2024.
They charge employers and government programs like Medicare multiple times the wholesale price of the drug, and they keep the difference. They lost almost 400 independent pharmacies. But this is not equal, and it's not just. They're social engineering you out of business.
Bipartisan legislation to crack down on the most nefarious price gouging abuses by pharmacy benefit managers that drive up prescription drug costs.
3 weeks and 2 days after my husband passed away, because this shit's important. I need to fight for our patients, for our community pharmacists, because every one of us is a patient, and every one of those PBMs takes our patients away from us. They harm patients, We have to stand up. Those that can speak up should speak up. Freaking speaking up, fiddlesticks.
So hopefully we are just one of the arms locked in with others that says this is just one more piece of information that we've had enough, and we're hoping to connect with enough people to say this is what's happening, we can fix it. And we've been asked by legislators that the last thing we need is for enough people at home to know what's happening and call up and says enough. One of the things you're going to hear time and time again is your phone calls matter. You call your legislator and says, okay, I understand a better thing. We need to have PBM reform. We need to have it where people can't extort and manipulate us because they can. We have incredible facilities, incredible people, incredible technology. We can prevent 80% of disease. Then why aren't we? Because the current health plans are designed to healthcare profiteer, not to actually help people prevent disease and lower cost. Who wants lower cost? Everybody else. What patient doesn't want to feel good and feel better? What employer doesn't want to give more benefits, have their people healthier and happier? Everybody else does, except for the folks who are actually in charge to administer it. And you're going to see all kinds of evidence. And the good news is we already know how. We just got to do it now.
Mr. Speaker, I rise today in honor of the late Cole William Schmidtknecht. No family should suffer the loss of a child from PBM greed. Ahead of Thanksgiving, we reached our goal of 50 co-sponsors to Pharmacists Fight Back, 25 Republicans and 25 Democrats. This is not a partisan issue. Cole had his whole life ahead of him. Because Cole was forced to choose between paying his rent or shelling out hundreds of dollars to cover his medication out of pocket for a drug that did not need to be that expensive, his family is without their loved one. There's no justification for a family facing Thanksgiving without their child. Cole's death was preventable. Since Cole's passing, Bill and Shannon, who are here today, have fought tirelessly for PBM reform. I am grateful for their presence today and that they have chosen to tell their story so no other parents experience this pain. Cole's parents said that Cole walked his own path in life. He was known by his loved ones to have deep care and compassion for those he encountered. I encourage my fellow members to protect patients like Cole and his family and to sponsor H.R. 9096, the Pharmacists Fight Back Act. In honor of Cole Schmidtknecht, we will carry forward the fight to end the price gouging abuses of pharmacy benefit managers. Thank you, Mr. Speaker, and I yield back.
Whispers grow louder, stories unfold.